Imagine waking up in the middle of the night and your face is just burning as if you've slathered it in acid. You go to the mirror and see your jawline erupting in these painful, deep cysts.
And, while that's happening, you're simultaneously dealing with this undeniable, maddening sensation of microscopic insects crawling just beneath the surface of your skin.
Right. For millions of women hitting perimenopause, this isn't a scene from a horror movie. It is, it's just a random Tuesday.
Yeah, I mean, we usually expect aging skin to follow a predictable linear path, right?
Exactly. Like it gets a little drier over the years, you get a few fine lines, you buy a heavier moisturizer, and, well, that's the deal.
The expectation is definitely a straightforward progression. But the reality of a hormonal transition is anything but.
Welcome to today's deep dive. We are talking directly to you, the listener who might be staring in that mirror right now, just completely baffled by what is happening to your face and your body.
It's a very isolating feeling, but you are absolutely not alone in this.
Today, our mission is highly relatable and, frankly, vital. We are going to solve the mystery of why your skin is suddenly betraying you, why it's acting like an angry teenager while feeling like a parched desert.
And most importantly, we are going to look at a concrete, evidence-based game plan to actually fix it.
And to do that, we have some incredible source material today. We're completely bypassing the beauty blogs and the marketing hype.
Yeah, we are pulling from a stack of rigorous medical sources. We're looking at the clinical guidelines from the British Association of Dermatologists, the BAD, alongside the official NICE guidelines.
Plus a wealth of recent peer-reviewed dermatological studies that focus exclusively on menopausal and perimenopausal skin changes.
Which is such a crucial area of study that finally is getting the attention it deserves.
Okay, let's unpack this. To really understand what is going wrong, I want you to imagine your skin as a delicate, perfectly balanced ecosystem. Like a rainforest, perhaps.
That's a great way to visualize it.
What happens in perimenopause is that this ecosystem experiences a sudden, violent shift in its climate. The foundational rules of the environment change basically overnight.
What's fascinating here is that modern medicine demands we completely discard this notion of skin as just a decorative wrapper.
Right, because we are so conditioned to think of it as a canvas that we just wash, moisturize, and try to keep smooth.
Exactly.
Yeah.
But the medical literature defines your skin as a massive active endocrine organ. I mean, it is loaded with hormone receptors, specifically estrogen receptors known as ER-beta.
So it's actually wired into the internal systems.
Highly wired, because your skin is literally connected to your endocrine system. A change in your internal hormonal climate doesn't just reflect on the surface. The skin actively participates in the physiological withdrawal.
Wow. Well, let's start with the first massive climate event in this ecosystem, which the sources highlight as the Great Drought.
The drought is really the catalyst for everything else.
Yeah, reading through the research, this loss of moisture isn't just an annoyance, is it? It is a structural collapse that triggers every other symptom.
It absolutely is. The sudden plunge in systemic estrogen is the architect of that drought, because estrogen is basically the master regulator of skin hydration and structural integrity.
How does it regulate it exactly?
Well, in a premenopausal state, estrogen continuously binds to those ER-beta receptors on the fibroblasts. And fibroblasts are the cellular factories in the deeper layers of your skin.
So it acts like a project manager.
Yes, exactly. It acts like a project manager, relentlessly ordering those factories to produce collagen, hyaluronic acid, natural oils, and ceramides.
Oh, let's pause on ceramides for a second because the sources talk about them constantly. If we visualize your skin cells as the physical bricks in a protective wall, the ceramides are the lipid mortar holding all those bricks together, right?
Spot on. They make up roughly half of the lipid matrix of your skin barrier.
So when estrogen drops, that project manager basically leaves the building and the production of that vital mortar completely halts.
And the clinical data tracking this decline is just staggering. Studies show that in the first 5 years after menopause, women can lose up to 30% of their skin's dermal collagen.
Wait, really? 30% in just 5 years?
I know, it sounds impossibly fast.
That is a massive structural collapse in an incredibly short window of time.
It is. The research calculates that skin thickness decreases by 1.13% and collagen content declines by a full 2% every single year after menopause.
So this isn't just normal chronological aging then?
No, not at all. A woman who goes through surgical menopause at, say, 35 will experience this exact same accelerated degradation. It is a direct, measurable consequence of estrogen withdrawal starving those fibroblasts.
Okay, so when you lose that structural collagen and your ceramide mortar crumbles away, the dermatologists point to a specific chain reaction. I think it's called TEWL.
Yes, transepidermal water loss, TEWL. Because the barrier is compromised, essentially it's full of microscopic fissures now, the osmotic gradient of the skin fails.
Meaning it can't hold on to water anymore.
Right. The moisture you desperately need inside your skin literally just evaporates out into the surrounding air.
And because those microscopic holes are letting all your hydration evaporate out, it means environmental irritants are suddenly able to sneak their way in.
Exactly. It's a two-way street of barrier failure.
So things like laundry detergents, synthetic fragrances, or even just dry winter air are penetrating deeper than they ever have before.
Which is incredibly disruptive to the local tissues.
This completely explains the phenomenon where a moisturizer you have happily used for a decade suddenly makes your face sting and burn like fire. The product didn't change at all. Your barrier's defense system is just gone.
And when that happens, the localized immune system in the skin goes into immediate overdrive because it registers those penetrating irritants as foreign invaders.
Which brings us to the neurological side of this crisis. Because your barrier is acting like a leaky sieve and your immune system is panicking, the natural result is severe itching.
The medical literature uses the term pruritus.
Right, pruritus.
Yeah.
And looking at the prevalence in the studies, it affects anywhere from 21% to 64% of women in this life stage. But I have to admit some confusion here.
Oh, what's confusing about it?
Well, I mean, I've had dry skin in the winter before, and, it's a little annoying. But the patients in these studies describe this as an aggressive, sleep-destroying agony. Is this really just dry skin, or is something more sinister happening in the nervous system?
It is entirely neurological. The dryness is merely the match. The nervous system provides the gasoline. The hidden chemical culprit driving this severe itch is actually histamine.
Wait, histamine, like the chemical responsible for hay fever and allergic reactions?
The exact same molecule, yeah. In a healthy premenopausal state, estrogen actually acts as a stabilizer for mast cells.
And those are the immune cells in the skin that store histamine.
Correct. Estrogen keeps the mast cell membranes robust, preventing them from degranulating or exploding unnecessarily. When estrogen levels plummet, that stabilization just vanishes.
So they just burst at random.
They become incredibly hyperreactive and trigger-happy. They start dumping massive amounts of histamine directly into the skin tissue at the slightest provocation. And histamine is the primary neurochemical that binds to nerve endings and fires up the itch-scratch cycle.
It's like estrogen was the bouncer at the club, keeping everyone calm, and the second the bouncer leaves, the mast cells just start throwing histamine everywhere.
That's a perfect analogy, and the sources point out a brutal circadian rhythm to this too.
Yeah, the listeners dealing with this know the itch always gets exponentially worse at night. Why is that?
The nighttime exacerbation is a classic clinical presentation. Endogenous histamine levels naturally peak in the human body during the late evening and night.
Oh, wow, so you're already fighting a losing battle when the sun goes down.
Exactly. And combine that natural histamine peak with the temperature fluctuations of perimenopausal hot flashes and night sweats, and you have a perfect biological storm.
Because the heat makes it worse.
Yes. The sudden heat and sweat further irritate that weakened, fissured skin barrier. The mast cells dump even more histamine in response to the heat, which triggers relentless itching.
Which obviously severely disrupts your sleep architecture, which immediately spikes cortisol, a stress hormone I know we'll get to in a moment.
We definitely will. But while we are examining these nerve responses, we really need to address a symptom documented in these clinical papers that sounds absolutely terrifying.
Oh, right. The medical term is formication. Patients report the vivid, tactile sensation of insects crawling on or just underneath their skin.
It is intensely distressing.
I mean, if you don't know this is a documented symptom of menopause, feeling phantom bugs crawling on you would make you feel like you were having a psychiatric break.
The distress it causes cannot be overstated. But clinical neurology provides a very clear, vindicating answer here. This is not a hallucination.
It's not.
No. Formication is a genuine physiological event caused by hormone withdrawal, altering the activation thresholds of the cutaneous nerves.
Wait, the physical nerve endings are actually misfiring.
Yes. Glutamate fibers responsible for transmitting the sensation of itch and temperature. They require estrogen for regulatory support.
Okay, so without estrogen.
Without it, their action potential, the threshold required for them to send a signal to the brain drops so low that they begin firing spontaneously.
So they're sending signals for no reason.
Exactly. They send these bizarre, crawling, tingling signals up the spinal cord to the somatosensory cortex, even when there is absolutely no physical stimulus on the skin.
Wow. Okay, here's where it gets really interesting, though. We have established a landscape that is structurally thin, leaking water, neurologically hyperactive, and completely dried out.
A very fragile terrain.
Right. And on this parched, fragile terrain, women are suddenly developing deep, painful acne breakouts like they are 15 years old again. Biologically, how is that even possible?
It does seem like a contradiction, doesn't it?
Completely. If my oil factories are shutting down because estrogen left the building, where's the acne coming from?
If we connect this to the bigger picture, we have to look at the entire endocrine panel, not just estrogen. Menopausal acne operates on a completely different mechanical pathway than teenage acne.
Because teenage acne is an absolute surge, right? Like an explosion of every hormone in the body simultaneously.
Right. But menopausal acne is driven by a state of relative androgen dominance.
I love the analogy we were using to make sense of this earlier. Imagine your hormones are a choir. You have the sopranos and altos, representing estrogen and progesterone.
And then you have the bases, representing the androgens, which are male typical hormones like testosterone.
So during perimenopause, the sopranos and altos suddenly walk off the stage. Estrogen and progesterone just drop completely out of the biological mix.
And the bases, the androgens, don't actually start singing any louder. Their absolute levels might even be declining slightly as you age.
But because the sopranos are completely silent, the bases dominate the acoustic space. Their relative volume is deafening.
Yes, and that relative dominance fundamentally alters the environment of the pore. Progesterone usually counterbalances androgens at the sebaceous gland, calming oil production.
So without progesterone, the oil glands overreact.
Exactly. With androgens dominating the receptor sites, the oil glands are stimulated to overreact. But the crucial mechanical difference from teenage acne lies in the skin barrier we discussed earlier.
Because it's so thin and fragile now.
Right, the epidermis is thinner, and the cellular turnover rate is sluggish from the lack of estrogen. So the newly produced sebum isn't normal. It is thicker, stickier, and highly inflammatory.
And the dead skin cells aren't shedding fast enough to clear the exit, so this bad sticky oil just gets trapped deep underground.
Exactly. The trapped sebum creates a microscopic bottleneck. And Cutibacterium acnes, the bacteria that lives naturally on the skin, thrives in that trapped, oxygen-deprived environment.
Which causes those deep cysts.
Yes. The result is deep, inflammatory cystic nodules rather than your standard surface-level whiteheads. Furthermore, because of the specific dense distribution of androgen receptors on the lower face, this acne almost exclusively targets the jawline, the chin, and the upper neck.
And the sources heavily emphasize a stress multiplier, compounding this entire process, too.
Cortisol.
Yeah, we talked about how the itching and the night sweats destroy your sleep architecture. That chronic sleep deprivation, combined with just the general psychological turbulence of this life stage, absolutely spikes your cortisol.
And cortisol is the primary stress hormone, and its relationship with adult acne is vicious.
How does it actually trigger the acne, though?
Well, the hypothalamus detects the systemic stress from sleep deprivation and signals the adrenal glands to pump out cortisol. But the adrenal glands concurrently produce DHEAS, which is an adrenal androgen.
Another base for the choir.
Exactly. And the skin contains specific enzymes that convert that circulating DHEAs directly into potent testosterone right there in the tissue.
Oh, wow. So the stress of the hot flashes biologically fuels more sticky sebum, locking the patient into an endless, frustrating cycle of breakouts.
It's a self-perpetuating loop, unfortunately.
So what does this all mean? We know exactly why the ecosystem is collapsing. The moisture is evaporating, the nerves are misfiring, and relative androgen dominance is trapping thick oil under a sluggish barrier.
The mechanics are perfectly logical, even if they are maddening.
Very logical. But how do we fix it? Let's look at the evidence-based playbook from the clinical guidelines. And just to be clear to the listener, we are impartially reporting the medical protocols laid out in these clinical sources to help you understand the landscape of options.
Right. This is informational.
Exactly. We are not prescribing this to you directly. You must always consult your physician. But let's look at the strategy here. What's the first step?
The foundational rule of the clinical playbook, echoed across all dermatological literature, is a strict barrier-first approach.
Meaning no harsh treatments.
Right. Because the menopausal skin is already compromised, attacking these jawline cysts with harsh teenage acne products, like aggressive physical scrubs, high-concentration salicylic acid, or alcohol-based toners, will utterly decimate whatever fragile barrier remains.
It just severely worsens the inflammation.
Exactly. The protocol begins with gentle, non-alkaline cleansers and rich moisturizers, heavily formulated with ceramides.
To artificially replace that missing lipid mortar we talked about.
Exactly. You have to patch the wall first.
Okay, my instinct is that replacing the mortar from the outside is just a band-aid, though. If the root cause is a plummeting estrogen level and a relative takeover of androgens, why wouldn't we just fix the internal choir?
Well, you're right on the money. Systemic intervention is often the most effective route. For women experiencing the broad spectrum of these symptoms, the profound dryness, the pruritus, the formication, and the structural thinning hormone replacement therapy, or HRT, is a foundational root cause fix.
How exactly does HRT fix the skin mechanics?
By restoring circulating estrogen, HRT allows the hormone to bind once again to the ER-beta receptors on those dermal fibroblasts. This physically restarts the cellular factories, stimulating collagen synthesis and natural hyaluronic acid production.
And what about the histamine issue?
Simultaneously, the restored estrogen restabilizes the mast cell membranes, halting the endless dumping of histamine and eliminating that intractable itch.
But the clinical data shows HRT isn't always enough to stop the specific jawline cystic acne, right?
That's true. Sometimes it needs an extra push.
Yeah, the BID guidelines highlight another highly effective systemic treatment specifically for the acne side of things. It is an off-label use of a cardiovascular drug called spironolactone.
Spironolactone has become a total cornerstone in adult female dermatology. The guidelines extensively reference a major clinical trial known as the SOFA study spironolactone for adult female acne.
And what did that study show?
It demonstrated remarkable efficacy for persistent hormonally driven cysts that failed to respond to standard care.
Wait, if the root issue is falling estrogen, my first instinct is that spironolactone must just be synthetic estrogen. But looking at the SOFA study, it's actually the opposite. It's an anti-androgen. Help me square that circle.
Yeah, it doesn't add any sopranos to the choir. It acts as a volume dial for the basses.
Ooh, I like that.
Spironolactone is a competitive antagonist at the androgen receptor. It physically occupies the androgen receptors on the sebaceous glands, blocking testosterone and DHT from binding.
So because the androgens cannot dock at the receptor site, the oil gland never receives the signal to produce that thick inflammatory sebum.
Exactly. It shuts down the overproduction at the source.
The SUFA study notes the typical dosing starts at 50 milligrams a day, eventually titrating up to a maximum of 200 milligrams based on clinical response. But they explicitly list a very serious caveat for the perimenopausal demographic.
Yes, clinical safety protocols are completely non-negotiable here. Primary care guidelines mandate that for patients over the age of 45, baseline renal function and serum potassium levels must be checked before initiating spironolactone.
And monitored periodically throughout treatment, right?
Correct. Because it was originally developed as a potassium-sparing diuretic, it can cause dangerously high potassium levels if kidney function is impaired. It is also strictly contraindicated if there is any chance of pregnancy.
Okay, so balancing internal hormones makes sense, but what if HRT or spironolactone aren't options for someone due to medical history? Or maybe they just want to treat the local breakouts topically.
The NICE guidelines have very specific recommendations on topical treatments for this, and it's probably not what you'd expect.
Yeah, well, traditional benzoyl peroxide is mentioned. The true gold standard for sensitive perimenopausal skin in these guidelines is actually topical azelaic acid, typically prescribed at a 15% or 20% concentration.
Yes, azelaic acid is fantastic for this demographic.
But why does the medical literature prefer azelaic acid over the classic teenage acne creams?
It comes down to its dual action mechanism and its high tolerability. Azelaic acid is deeply comedolatic, meaning it normalizes the chaotic shedding of dead skin cells, clearing that microscopic bottleneck in the pore.
So it unplugs the drain.
Exactly. It is also powerfully antimicrobial against the acne bacteria. But crucially, unlike harsh retinoids or high-dose benzoyl peroxide, azelaic acid is fundamentally anti-inflammatory.
So it aggressively treats the cystic breakouts while actually respecting that fragile estrogen-deficient barrier?
Precisely. It doesn't cause the same collateral damage.
Now, what if a dermatologist steps up the treatment to an oral antibiotic? I was genuinely surprised by how incredibly strict the NICE guidelines are regarding antibiotics for skin conditions.
Antimicrobial stewardship is a massive, urgent focus in modern clinical guidelines. If a patient is prescribed an oral antibiotic for inflammatory acne, typical limecycline or doxycycline, the absolute mandate is that the course must be strictly limited to a maximum of 12 weeks.
12 weeks maximum. Wow, so you can't just take a low dose forever to keep your skin clear.
Doing so accelerates the global crisis of antibiotic resistance. The bacteria will simply mutate and become immune to the drug.
So what's the clinical strategy then?
The strategy is to use the oral antibiotic as a short-term fire extinguisher, just to rapidly calm the severe, painful inflammation for 3 months. During those 12 weeks, the patient must simultaneously use a topical treatment like azelaic acid. Once the 12 weeks are up, the systemic antibiotic is discontinued and the topical treatment continues indefinitely for maintenance.
Got it. And there is one specific antibiotic the guidelines explicitly red flag.
Yes, the guidelines are unambiguous. Minocycline should not be used.
Why is that?
It carries unacceptable risks of severe adverse events, including drug-induced lupus erythematosus, autoimmune hepatitis, and irreversible blue-gray pigmentation of the skin and teeth.
Yikes. So doxycycline or limecycline remain the standard of care.
Exactly.
You know, it is so incredibly empowering to actually trace the biological mechanisms behind all of this. It takes the mystery and, more importantly, the self-blame completely out of the equation.
It really does. It's just biology, not a personal failing.
To recap our journey today, if you are experiencing the bizarre paradox of skin that is paper-thin, evaporating moisture, itching uncontrollably in the middle of the night, and yet erupting in deep cysts along your jawline, it is not random.
Not at all.
It is not because you bought the wrong face wash or, didn't drink enough water. Your skin is reacting with perfect physiological logic to an internal climate crisis. It's an estrogen drought, a massive histamine spike, and a relative androgen takeover.
This raises an important question, though, one that steps slightly outside the clinical guidelines and into evolutionary biology.
Oh, I love these tangents. What is it?
Well, we spent this entire time dissecting how deeply, utterly dependent human skin is on estrogen to maintain its structure, retain water, and regulate its nerves.
Right, without it, the whole ecosystem collapses.
Which leaves us with a profound biological mystery. Why did human skin evolve to rely so heavily on a specific hormone that naturally, predictably vanishes halfway through the human lifespan?
That's a really good point.
From an evolutionary perspective, human females are uniquely long-lived after menopause, often living decades beyond their reproductive years. It's a phenomenon some anthropologists attribute to the grandmother hypothesis, where older females help ensure the survival of the wider family unit.
Oh, interesting. So we are meant to live a long time post-menopause.
Exactly. Yet our skin's biology seemingly never got that memo.
Yeah.
It acts as if it was only designed to function properly during our reproductive years. It challenges us to wonder if this dermatological collapse is an evolutionary oversight, a reallocation of bodily resources, or maybe a puzzle we simply haven't solved yet.
That is a fascinating thread to pull on. It makes you realize that treating your skin during this transition isn't just about trying to recapture youth. It's about supporting an organ navigating an evolutionary blind spot.
Well said.
Thank you so much for joining us on this deep dive. We hope you take this clinical playbook and a healthy dose of self-compassion back to your daily routine and, more importantly, directly to your doctor or dermatologist.
You do not have to just suffer through the drought and the breakouts.
Exactly. The ecosystem can be brought back into balance. Until next time, take care of yourselves and take care of your skin.